Welcome students to Chapter 16. We're covering disorders common among children and adolescents in this chapter. And we know that abnormal functioning can occur at any time in life. Children of all cultures typically experience at least some emotional and behavioral problems as they encounter new people and situations as they grow. Things like bedwetting, nightmares, temper tantrums, and restlessness we find across cultures. Adolescence can also be a difficult period with the physical and sexual changes that come with maturing. Social and academic pressures, personal doubts, and temptation cause many teenagers to feel anxious, confused, and depressed. We also see bullying coming into play in childhood and adolescence, with 20% of students reporting being bullied frequently, and more than 50% reporting having been a victim at least once. All victims of bullying are upset by it, but some individuals seem to be more traumatized by the experience than are others. You can see on this slide, on the left-hand side, there's the percentage of respondents who say that the child experiences stress, and then there are areas of childhood stress that go across the bottom. Child respondents, you can see note much more stress than parent respondents. So I think we oftentimes underestimate the difficulties that children have as they go through their growing up. And then when we have something like COVID come along, the normal pressures and stresses of childhood and adolescence are increased with society's efforts to contain a virus or to, try to combat some kind of conflict in the world. All these kinds of difficulties compound the normal pressures that children and adolescents face. Some disorders of children, such as childhood anxiety disorders and depression, have adult counterparts, where other disorders, like elimination disorders, usually disappear or change form by adulthood. And some disorders begin in birth or childhood, and they persist in stable forms into adult life, things like autism spectrum disorder and intellectual disability. Some level of anxiety is a normal part of childhood. Common events, parental problems or inadequacies, genetic influences such as anxious temperament, all of these things can produce anxiety. At least 25% of all children and adolescents do experience an anxiety disorder, though. In childhood, we have separation anxiety disorder that's displayed by at least 4% of all children, where there's extreme anxiety, often panic, when they're separated from home or a parent, and they may have school refusal because they do not want to leave home or their parent. Another disorder is selective mutism, where children consistently fail to speak in certain social situations, but in others they have no problem. It begins as early as the preschool years, and it may be misinterpreted as intellectual disability. About 1% of children are affected. Despite the high prevalence of childhood and adolescent anxiety disorders, 2/3 of anxious children go untreated. There are psychodynamic, cognitive, behavioral, and many other treatments that can be used. And a very, very efficacious method of treatment is play therapy, where children use toys, they draw, they make up stories, and in doing so, they're thought to reveal the conflicts in their lives and their related feelings. You can see huge improvements with play therapy many times. Depressive and bipolar disorders during childhood do account for 2% of children and 8% of adolescents experiencing major depressive disorder, and as many as 20% of adolescents experiencing at least one depressive episode, while other clinicians suggest that children can experience bipolar disorder as well. Many times these disorders may be precipitated by child abuse. Between 5 to 16% of children in the U.S. are physically abused each year, usually by parents. Victims may suffer both immediate and long-term psychological effects. Short-term effects include anxiety, depression, and bedwetting, and long-term effects include lack of social acceptance, alcohol and substance abuse, and impulsivity. As many as a third of those abused grow up to be abusive, neglectful, and inadequate parents themselves. I mentioned that some clinicians believe that there is childhood bipolar disorder, and that has actually been reclassified as disruptive mood dysregulation disorder in the DSM-5. So children who for at least a year repeatedly display severe outbursts of temper that are out of proportion to triggering situations and are different from ones displayed by most other individuals of his or her age, are going to have DMDD. The outbursts occur at least 3 times per week, and they're present in at least 2 settings. There's irritable and angry mood between the outbursts, and the individual receives initial diagnoses between 6 and 18 years of age. Children also can display oppositional defiant disorder, which is exactly what it sounds like. They're argumentative, they are defiant, angry, irritable, and sometimes vindictive. Conduct disorder is a more severe problem in which children repeatedly violate others' basic rights. Often they are aggressive and physically cruel to people and animals. They may steal, threaten, or harm victims. Begins between 7 and 15 years of age, and there are various patterns that children can follow in this type of disorder. To treat it, people receive parent management training. There's also child-focused treatments, including cognitive behavioral interventions, problem-solving skills, coping, and drug therapy. Sometimes it gets to the point where children need residential treatment in foster care or juvenile centers. And there's also prevention efforts, including training opportunities, recreational facilities, and health care. Another type of childhood disorder is the elimination disorders. Children with elimination disorders repeatedly urinate or pass feces in their clothes, in the bed, and on the floor. They've already reached an age, though, in which they're expected to control these bodily functions. They're not caused by physical illness, more by a psychological problem. Enuresis is involuntary bedwetting or wetting of one's clothes. It typically occurs at night but can occur during the day, may be triggered by stress, and children have to be at least 5 years of age to receive the diagnosis. Most cases correct themselves without treatment. Encopresis is defecation into clothing. It's less common than enuresis and less well researched. It's usually involuntary and seldom occurs during sleep. It tends to start after the age of 4 and is more common in boys. Neurodevelopmental disorders is a group of disabilities in the functioning of the brain that emerge at birth or during very early childhood, and these affect the individual's behavior, memory, concentration, or ability to learn. ADHD, or attention deficit disorder, is one. Children who display ADHD have great difficulty attending to tasks. They behave overactively and impulsively, or both. Primary symptoms of ADHD may feed into each other, but in many cases one of the symptoms stands out more than the other. And there are other problems that ADHD creates for children, including learning or communication problems, poor school performance, difficulty interacting with others, misbehavior, and mood or anxiety problems. Treatment involves about 80% of all children and adolescents with ADHD. Most commonly applied approaches are drug therapy, behavioral therapy, or a combination of the two, and the combination is the most successful approach. The drug therapy is provided to millions of children and adults. Ritalin or methylphenidate is one class of drugs, and then Adderall is another major class of drugs. There are long-term effects, including applicability to children and minority groups, inaccurate diagnosis and misuse. So these drugs have to be carefully administered and monitored. Cognitive behavioral therapy and treatment combinations are also used for these concerns. Operant conditioning, for example, the token economy, may change people's behavior. Therapeutic summer camps and parent management training is also helpful. Most improvement, again, comes from treatment combinations. Autism spectrum disorder is another neurodevelopmental disorder that was first identified in 1943. Children with this disorder may be very unresponsive to others, uncommunicative, repetitive, and rigid. Symptoms appear early in life, before age 3. At least 1 in 60 children display the pattern. Around 80% occur in boys, although there is a less prominent symptoms that occur in girls that are being more readily identified today. As many as 90% of children with the disorder remain significantly disabled into adulthood. Even the highest functioning adults with autism typically have problems in social interactions and communication, and they have restricted interests in activities, for example, things like being obsessed with Star Wars or something like that. They may have lack of responsiveness and social reciprocity. They may have language and communication problems that take various forms, such as echolalia or echoed speech, pronoun reversal, nonverbal, unusual behaviors, and they may be, as I said before, highly rigid. They may have many repetitive behaviors like rocking or banging or things like that. They may have interests in activities that are highly unusual and extend beyond speech patterns. Cognitive behavioral therapy is used for autism in many cases. Communication training is also highly necessary for both sometimes verbal and nonverbal communication, as well as social communication. Parent training is very helpful as well, and integration among community providers really is very important. There is no known treatment that totally reverses the autistic pattern, although there are many adults who have outgrown many symptoms of it, and so they function well in society if they are high functioning. Intellectual disability is the last neurodevelopmental disorder that we'll talk about. This term replaces the term mental retardation. According to the DSM-5, people should receive a diagnosis of intellectual disability when they display general intellectual functioning that is well below average in combination with poor adaptive behavior. That's sort of like the skills that you need for everyday functioning, like social interaction and self-care and interacting in the community and things like that. Symptoms must appear before age 18 for a diagnosis. When is therapy needed for intellectual disability? Sometimes we all experience emotional and behavioral problems, so individual and group therapy can be provided, but it needs to be provided by someone who can treat that level of intellectual functioning. And then psychotropic medications also sometimes are prescribed. Also, there's lots of ways that we can promote personal, social, and occupational growth for people with intellectual disability. Things like youth clubs, Special Olympics, dating skills programs, sheltered workshops so they can work, and a complete range of educational and occupational training services are important. These remarks conclude what I have to say about Chapter 16, and I will pick up our conversation in Chapter 17.